Good evening, and welcome to our webinar, What Your Doctor May Not Tell You About Cognitive Decline. I'm David Ward, Chief Science Officer and Director of Functional Healthcare Services for Entavita. We're really excited that you've taken the time to join us this evening so that we can share this very important information with you. Now, before we start, it's important to lay out some ground rules, so to speak. First, if you have any questions, please type them into the Q&A, and we'll do our best to address them at the end. Also, as we go along this evening, if you would like to explore working with us, we offer a complimentary 30-minute discovery consultation, and the link to schedule is in the chat. Also, we're recording this evening's presentation, and if you're interested in receiving the recording, let us know in the Q&A, and we'll let you know how to obtain it. Also, please keep in mind that the information, comments, and opinions expressed in this presentation are those of me as the speaker, based on my own clinical experience and interpretation of the literature. And it is intended for education purposes and not intended as a substitute for medical care. The lifestyle and nutrition approach presented is not suggested as a cure for any disease. Please talk to your healthcare provider about any information you get from this presentation. Now, I'm going to review the current standard of care with the conventional medical approach for cognitive decline. And frankly, it may sound like some gloom and doom, but I would not talk about that without providing solutions. So please hang with me as I go through some of the science of cognitive decline. And then later I'll be discussing how you can take proactive steps to reverse or prevent cognitive decline. Now, specifically, what we're going to be covering this evening is why the prevailing paradigm of what causes Alzheimer's disease might not be accurate. What are the real underlying causes of the brain changes that can lead to Alzheimer's? Why the current drugs approved by the FDA for Alzheimer's do not stop the progression from cognitive impairment to dementia, and how chronic low-level inflammation is the match that lights the fire in the brain, resulting in the degenerative process leading to cognitive impairment. Why a normal brain function test might not be an accurate indication that there isn't already a problem. How hormone and nutrient deficiencies, insulin resistance, toxins and infections can result in brain changes that lead to Alzheimer's, often 20 years before symptoms are noticed. And what you can do to identify your risk factors, take proactive steps to prevent cognitive decline, and support a healthy aging brain. Now, whenever I present information about a topic that may be controversial in the sense that it goes against the prevailing paradigm, I like to remind everyone to be open-minded, but not so open-minded that your brains fall out. One of my mentors likes to say, always start with why. So I'd like to share my why for the work that I do here at Entavita. And my why started 47 years ago in 1975 when I was diagnosed with the autoimmune disease lupus. Very long story short, I struggled with the conventional medical approach for a number of years as I experienced many severe flare-ups and short-lived remissions. And it was only when I discovered the functional healthcare approach that I identified the underlying causes for my autoimmunity and used a targeted lifestyle-based approach to remove those triggers that I was able to achieve long-term remission. I like to say that conventional medicine kept me alive, but functional healthcare gave me my life back. As a chiropractor, I was practicing this lifestyle-based approach for restoring and maintaining health and preventing disease, primarily working with individuals with autoimmune and chronic inflammatory disorders, when I learned about a program developed by Dr. Dale Bredesen, a neurologist from UCLA, for reversing and preventing cognitive decline. Now, my grandmother had died from what at the time was called senile dementia, and looking back, it was probably Alzheimer's, and my mother died with Alzheimer's. So this topic was very personal to me. And in 2017, I was one of the first 1,500 practitioners worldwide to be trained in Dr. Bredesen's approach that we've integrated here at Entavita and that I'm going to be sharing with you this evening. So let's start by defining what cognitive impairment is. And it's when a person has a trouble with remembering, learning new things, focusing or concentration, or making decisions that affect their everyday life. And cognitive impairment ranges from mild to severe, and more than 16 million people in the United States are living with cognitive impairment. Now, this is a graph that shows the prevailing view of the decline in cognitive function over time. And in this model, cognitive decline starts with preclinical symptoms, which is a subtle decline from one's own baseline that's more than what would be expected with normal aging. So you could see the difference between these two lines here. But they would not yet meet the criteria for a diagnosable condition. Now, not all individuals experiencing cognitive decline progress further along this continuum shown here. And those who do continue to decline progress typically next to mild cognitive impairment, or MCI, where there is a noticeable decline in function that's measurable with testing. And among those with MCI, about 15% develop dementia after about 2 years. And Alzheimer's disease is the most common form of dementia. Now, it's important to recognize that there are no conventional medical treatments for preclinical or mild cognitive impairment. You have to have progressed to dementia or Alzheimer's disease for any of the FDA-approved drugs. Keep that in mind as we go forward, and I'm going to be emphasizing that point further. Now, there are many causes for cognitive decline or impairment, and we all have bad brain days, such as after too little sleep or too much stress. And some decline may occur in some individuals as they age. But when it becomes an ongoing issue, it's important to take action early to rebuild your brain function. Now, Dr. Bredesen says there's a problem with mild cognitive impairment, and that's analogous to saying mildly metastatic cancer, meaning that it's a relatively late stage of the disease process. And he suggests that cognitive impairment occurs in 4 phases. In phase 1, you're asymptomatic, meaning you don't have any issues that you're noticing or others around you are noticing. However, your laboratory biomarkers and imaging findings can be abnormal, meaning we can see changes in your metabolism and in your brain. And these brain changes are typically seen 15 to 20 years before symptoms of dementia. In phase 2, you're in subjective cognitive impairment or decline, which is similar to that preclinical phase that we showed on the graph previously, where cognitive symptoms are present, but no abnormal cognitive testing is done. And this may actually last 10 years. And as I said, not everyone who starts to experience cognitive decline progresses further. Phase 3 is mild cognitive impairment. And again, cognitive symptoms are present. You have abnormal cognitive testing, but you have normal activities of daily living. So you still have the ability for your own self-care. And then phase 4 is Alzheimer's disease. And again, Alzheimer's is the most common form of dementia, where there are cognitive symptoms, abnormal cognitive testing, and your activities of daily living are affected. And the diagnosis of dementia is typically made 20 years after those initial biochemical changes. Now, excuse me, the FDA has approved 6 drugs for the treatment of Alzheimer's disease. 5 of these drugs temporarily treat symptoms, but they do not change the underlying brain changes that occur in Alzheimer's, nor do they alter the course of the disease. Those 5 drugs fall into the class here of cholinesterase inhibitors and memantine, and they're currently approved for the treatment of dementia. So again, not available for subjective or mild cognitive impairment. Similar to observational studies, meaning non-clinical studies, many participants in clinical trials receiving these drugs experience greater cognitive decline than those not receiving such medications. In other words, in both studies, research studies, and observationally, a lot of people get worse taking these drugs, and they stop taking them. The 6th drug, called aducanumab, was approved by the FDA in June of 2021, so just last year. And it's the first FDA drug approved to address what some believe is the underlying biology of Alzheimer's disease, rather than just the symptoms. And it does this by reducing what's called amyloid beta plaques in the brain. Now, I've emphasized what some believe because there is widespread disagreement about whether this view is actually accurate. Aducanumab is not a cure for Alzheimer's, and it's not appropriate for all individuals. Now, the prevailing view of what causes Alzheimer's, called the amyloid hypothesis, says that Alzheimer's is caused when a protein in brain nerve cells called neurons, that protein is called amyloid precursor protein, or APP. You could see I've circled it here. So this is a nerve cell. Okay, this is the inside of the nerve cell. Here's the amyloid precursor protein, or APP. When it's cut in a particular way, it forms amyloid beta. And that amyloid beta is chemically sticky, and it clumps together to form large plaques. And the plaques cause inflammation in the brain, leading to neuron degeneration and neuron or nerve cell death. In this model, inflammation is a late stage event that occurs because of the amyloid plaques. Now, these plaques also migrate into synapses. Those are the communication ports. Those are the points where 2 neurons communicate with each other. So there's a little space in between, and the plaques sit in between there, and they gunk up the works, and they prevent those neurons from communicating. Now, nerve cells are very, very social. They love to communicate. They love to be stimulated. And when they're not stimulated and communicating, they stop firing, and they shrink and downsize, and they become debris in the brain, and they get cleaned up through inflammation. So again, this theory is called the amyloid hypothesis. Now, there's a second protein in nerve cells called tau, which is also implicated in Alzheimer's. I don't show it here on this diagram. And tau becomes dysfunctional as a result of the accumulation of the amyloid plaques. That actually stimulates dysfunctional tau. And the dysfunctional tau forms clumps or tangles that also damage neurons. Now, if we look at all of the clinical trials that have been done on Alzheimer's disease drugs through 2019, of the over 2,000 clinical trials, 22.3% of them were based on the amyloid hypothesis. So over 400 trials based on the amyloid hypothesis. You can see here, this is the tau hypothesis. It's less than half of the amyloid, so it's not as prevalent in the thinking. So the amyloid hypothesis suggests that removing the plaques will stop Alzheimer's. And yet every single clinical trial, all 400 of these clinical trials, has failed. Every trial has failed to improve cognition or stop the disease process in a single subject. And in fact, some people have been made worse. Now, the authors of that paper said the most perplexing question is in regard to the amyloid hypothesis and its failed clinical trials. And they noted that the failure of these trials suggests that it's better to treat amyloid deposits as a feature rather than an effect rather than part of the mechanism or cause. So in other words, it's better to treat the amyloid as a result of the disease process, not the cause of the disease process. Now, I mentioned earlier that one of the drugs approved for Alzheimer's is aducanumab. And in 2019, 2 clinical trials on aducanumab were stopped because no evidence was presented to correlate biomarker changes to cognitive benefits. In other words, they removed the amyloid, but there were no cognitive benefits. And its efficacy as a treatment for the cognitive dysfunction in Alzheimer's could not be proven. Dr. Howard Phillott, the Chief Science Officer of the Alzheimer's Association Drug Discovery Foundation, was quoted as saying, "At this point, we've done the right experiment," meaning the drug did exactly what it was supposed to do. It was designed to remove amyloid, and it was great at doing that. But the hypothesis didn't hold true, meaning the amyloid hypothesis. The trial failed the hypothesis. And the FDA, in their approval, they said that they approved it because there is substantial evidence that Aduhelm, that's the brand name of aducanumab, reduces the plaques, and the reduction in these plaques is likely to predict important benefits to patients. Now, this confused people in the research community. There was a lot of problems associated with these drugs, and a lot of researchers were adamant that this approval never should have happened. And largely because the FDA approval was based on the ability to lower beta amyloid, and yet their own analysis showed that those amyloid changes did not change cognition or functional brain capacity for Alzheimer's patients. And in fact, in an independent panel of experts that reviewed the drug and made a recommendation to the FDA about the approval, 10 of the 11 panelists voted that the data presented could not be evidence of aducanumab's effectiveness. And after the FDA approved it anyway, 3 of the panelists resigned in protest. In addition to the fact that the drug really didn't work, 41% of the patients who received the high dose, the dose that the FDA approved, experienced either brain swelling or bleeding. Now, to me, as an athletic trainer, when I hear brain swelling or bleeding, like after somebody has a concussion, that gets my attention because that's how people die from concussions, is from brain swelling and bleeding. And 64 patients had to stop participating in the trials because of the swelling. And most of those experienced swelling, and 94 reported symptoms. And the most common symptoms reported were headache, confusion, dizziness, and nausea. So the drug that they gave to stop or reverse cognitive decline caused confusion. Recently, you may have heard that another drug made the press. This is called lecanemab, and it is designed to remove the protein amyloid beta from the brain. And some researchers are really excited about this because it slowed the rate of cognitive decline by 27%. Now, by comparison, aducanumab, when the FDA and the manufacturer jointly looked at the research again after the trials were discontinued, they found that aducanumab slowed the decline in a certain small subset of patients by 22%. So this one slowed the rate of decline by 27%. Again, No stopping the decline, no reversing the decline. So you ended up in the same place taking this drug than if you did nothing. You just take a little longer to get there. Dr. Madhav Tambasetti, a senior researcher at the National Institutes of Aging, who was not involved in the study, said the results represented a very small effect, and it's unlikely that these differences are going to be noticeable by individual patients in their everyday lives. And about 1 in 5 people who got lecanemab in the study experienced an adverse event, and again, swelling or brain bleeding. And symptoms were headaches, visual disturbances, and again, confusion. Now, this time, the treatment has been linked to 2 deaths. Now, the drug company has said the drug didn't cause the deaths. The deaths are not associated with it. But these were 2 people in the study who died. So you have to ask the question, what was it about the drug that caused their death? There's some suggestion that they were taking blood thinners and that caused hemorrhage, but a lot of people take blood thinners. So does that mean if you're taking blood thinners, this drug wouldn't be right for you? Possibly. This paper was published in The Lancet just a couple of days ago, December 3rd, and they noted that a trial that showed efficacy with clinical outcomes, in other words, a trial that made it all the way through phase 3, is welcome news, but the immediate impact of that result should not be overstated. And what they noted was, for now, the key message for Alzheimer's disease remains: target the modifiable factors for prevention, for dementia, to maintain brain health across the lifespan. In other words, prevent dementia by addressing modifiable risk factors such as hypertension, hearing impairment, smoking, physical inactivity, diabetes, traumatic brain injury, air pollution. Those are the things that they're referring to when they say modifiable risk factors. Now, this paper came out almost 10 years ago, and it noted that abnormal accumulation of amyloid and the tau begins 10 to 20 years before the onset of symptoms. And the authors suggested that interventions designed to prevent the accumulation of amyloid may be more effective than attempting to reverse the pathology after it accumulates. In other words, preventing the accumulation of it on the front end may be a better approach than waiting and trying to remove it on the back end. I love this quote that's attributable to Mark Twain. It says, "It ain't what you don't know that gets you in trouble. It's what you know for sure that just ain't so." Now, I had mentioned Dr. Bredeson's work earlier. In 2014, he published his first paper on reversal of cognitive decline. Now, we know that Alzheimer's disease is characterized by the presence of these amyloid beta plaques in the brain. However, the missing link in the amyloid cascade hypothesis has been, why does the amyloid become overexpressed in the first place? And in over 30 years of study, Dr. Bredesen found that as we age and we're exposed to multiple insults over time, an imbalance occurs between factors that cause this APP to go down this pathway that results in amyloid plaques, which we call an amyloidogenic or amyloid creating pathway, versus being cut or acted upon this way and going down this pathway, which is non-amyloidogenic, non-amyloid creating. And in fact, if the amyloid precursor protein goes down this pathway, it supports a healthy brain. It supports the growth of nerve cells and the building of synapses. Now, as insults occur in our brain, amyloid is produced in large quantities by nerve cells under stress. And I'll define what I mean by insults in just a minute. And this has led some to suggest that this amyloid precursor protein and the production of amyloid beta plaques are actually an adaptive, protective response to a variety of insults and actually part of the brain's immune system. So Dr. Bredesen said that what is referred to as Alzheimer's disease is actually a protective response to different insults, such as inflammation, insulin resistance, toxins, hormone or nutrient deficits, and infections. Any condition that would reduce oxygen, the delivery of nutrients, or the production of energy in the brain has the potential to lead to nerve cell stress and produce increased levels of amyloid beta. So for example, sufficient estrogen in women and testosterone in men causes amyloid precursor protein to be acted upon on this pathway, go down this way to increase synapse building. Inflammation and insulin resistance causes the amyloid precursor protein to be acted upon in this way to increase the production of amyloid plaques and the destruction of synapses. And diet, stress, sleep, exercise, and toxins all affect the balance in this amyloid precursor protein in terms of, is it going to go this way? Is it going to go that way? Dr. Bredesen discovered that there were at least 36 factors that affect whether the brain goes down a synapse destroying pathway or a pathway that maintains and preserves synapses. And he likens it to a roof with 36 holes. Now, if you have a room and the roof has 36 holes in it, it's going to be difficult to find a place to stand where you're not going to get wet. But if you can plug up enough of those 36 holes, you just might be able to find a place where you could stay dry. Now, while Dr. Bredesen published over 2,000 peer-reviewed papers in well-respected medical journals, he also started publishing case studies on his approach in 2014. And in 2019, there started to be more publications that were coming out that supported Dr. Bredesen's approach. Now, some of that research was presented at the Alzheimer's Association Annual International Conference, and the journal Scientific American published this paper that said, for decades, researchers have focused their attacks against amyloid on the two proteins, amyloid and tau. However, a series of observations and recently published research suggested a different path. And that is that Alzheimer's may actually be the result of brain inflammation. And in fact, the spark that starts the disease process might be some kind of an insult, perhaps a passing virus, a gut microbe, or a long dormant infection. And it was also noted that some people can have brains clogged with these plaques and tangles and still think and behave normally. Dr. Rudy Tanzi from Mass General Hospital and Harvard Medical School said that what made these people resilient was lack of brain inflammation. And Dr. Paul Morgan from Cardiff University noted that the accumulating evidence that inflammation is a driver of Alzheimer's is enormous. So we're starting to see the suggestion coming out around 2019 that in fact inflammation was an early stage event and not a late stage event, which the amyloid hypothesis suggests. Now, Dr. Tanzi suggests that the buildup of amyloid is a part of a necessary immune system protection response that can later lead to Alzheimer's disease. And he specifically noted that viruses and toxic metals are specific insults that result in overexpression of the amyloid plaques. And downstream inflammation as a result of these insults is the primary driver of nerve cell death and the onset of Alzheimer's symptoms. And removing the amyloid, which is the basis of the amyloid hypothesis, when it has accumulated as a protective immune response before the underlying insults have been addressed, has been suggested as a reason that some people were getting worse in clinical trials. Now, also in 2019, this paper came out that showed that Porphyromonas gingivalis, P. gingivalis, this is a bacteria that can accrue in the mouth. They were finding it in Alzheimer's brains, and they started to suggest that it was a causative factor for Alzheimer's. And Dr. George Perry, a very well-known and well-respected neurologist, noted that this is a further turning point in the understanding that infections and inflammation can be at the heart of Alzheimer's disease. And the studies then just kept coming. This one from 2020, scientists at Sloan Kettering identified a direct link between immune responses to viruses and bacteria in the brain and the development of plaques in the brain associated with Alzheimer's disease. In 2021, this study came out that showed inflammation in the brain drives the progression from the presence of amyloid to the onset of dementia. And they noted that in living patients, brain inflammation or activation of the brain's immune cells is not a consequence of the disease progression. Rather, it's a key upstream mechanism that is indispensable for disease development. And just this year, this paper came out that said, while there's no clear cause, no single clear cause of Alzheimer's, it's been found that chronic inflammation can lead to the production of the amyloid plaques, leading to their aggregation and inflammation that damages the synapses. This is some other research that supports multifactorial contributions to cognitive decline in Alzheimer's disease. So all of these factors create an environment in the brain that induces persistent neuron stress, brain inflammation, and the overexpression of amyloid. Mold, heavy metals, chronic stress, sleep disturbances, imbalance in the gut microbiome, hormone and nutrient deficiencies, all can be some of the insults or are some of the insults that drive this process. Now, I want to shift gears a little bit to talk about genetics as a risk for Alzheimer's disease. And you may have heard about Chris Hemsworth, the actor, who recently learned that he had a greater than average chance of developing Alzheimer's after he found out he had 2 copies of the gene ApoE4, which is linked to an increased risk of that disease. Now, everybody inherits 2 copies of the ApoE gene. You either get ApoE2, ApoE3, or ApoE4. And it's ApoE4 that confers the increased risk. So if you do not inherit one, you have an approximate 9 to 20% risk for Alzheimer's. If you inherit 1 copy, that risk increases to about 30 to 45%, and that represents about 75 million Americans. If you inherit 2 copies, like Chris Hemsworth did, the risk increases to approximately 50 to 90%, and that represents 7 million Americans. Now, the media has focused on this 90% risk. The reason that ApoE4 increases your risk is that it increases inflammation, and so it increases your risk because inflammation is at the heart of Alzheimer's disease. Now, there are 3 additional genes that were discovered by Dr. Tanzi's lab that are associated with early onset Alzheimer's, but they represent less than 5% of the cases. So the overwhelming genetic risk for the rest of us is associated with ApoE4. But it's important to keep in mind that your genes are not your destiny. 20 years ago, it was thought that genetics held the key to disease, both to disease causation and to cures for disease. But we've learned that most chronic diseases don't have a singular genetic cause. And the science of epigenetics, epi meaning above or beyond, so above or beyond genetics, shows that we can modify our gene expression through lifestyle and environmental factors. And the key to good epigenetics is good habits. The Finnish geriatric intervention study to prevent cognitive impairment and disability, called the finger trial. That's why they call it the finger trial, because nobody wants to say all of those words. So this was the first long-term, large randomized controlled trial that explored whether a multi-domain intervention could improve or maintain cognitive function in the general population. And this was published in the journal Lancet in 2015. It involved 1,100 people, ages 60 to 77. 362 of them had the ApoE4 gene. And the interventions were nutritional guidance, exercise, cognitive training, and vascular risk management. So managing things like hypertension, cardiovascular disease, things like that. And the results showed that the intervention was associated with a 25% overall greater improvement in cognitive function in the study participants, which is great. This was the first study that showed that lifestyle intervention could actually improve cognitive function. Remember, the drugs don't improve it. They slow the decline, or they manage the symptoms. The authors of the study also noted that healthy lifestyle changes can be beneficial for cognition, even at-risk interventions or individuals who have the ApoE gene. They also noted that the findings emphasize the importance of early prevention strategies that target multiple modifiable risk factors simultaneously. This study was published in the Journal of the American Medical Association in 2019. It included 196,000 participants of European ancestry without dementia. And what they noted was a healthy lifestyle was associated with a lower risk of dementia among the participants with either a low or high genetic risk. In other words, it didn't matter if they had the ApoE gene, the ApoE4 gene. Lifestyle overrode the genetic risk. They also noted that both genetic and lifestyle factors play a role in determining individual risk of Alzheimer's disease. And when we look at chronic inflammatory diseases in general, and Alzheimer's is really considered now to be a chronic inflammatory disease, we note that genetics plays a role, but a larger role is played by lifestyle and the environment. And in fact, chronic inflammatory diseases are an intersection of all of these factors. And all of these factors shown here, diet, exposure to toxic chemicals, the status of your gut bacteria, infections, those are all modifiable. And in fact, the way that you modify these components in your life through your habits promotes healthy genetic expression and prevents genetic expression of things like that ApoE4 gene to increase your risk. So how does one go about developing an effective treatment for Alzheimer's, which is considered to be an incurable disease? Well, step one starts with evaluation, and that begins with a questionnaire and history from both the subject experiencing the decline and a spouse or partner or significant other or some caregiver or other loved one who can comment knowledgeably about the subject who's experiencing the decline, about how they're doing in their lifestyle. And then we also use clinical cognitive assessment tools to identify the level or progression or stage of cognitive decline. So we start with what's called the Alzheimer's questionnaire, or the AQ-21. This is completed by, again, spouse, significant other, caregiver, a child. And this gives us information about how well the person who's experiencing cognitive decline participates in their activities of daily living, and also what are the kinds of things that are showing up related to the cognitive decline. So is it an inability to remember where they placed objects? Is it an inability to remember conversations? Is it an inability to navigate, especially in familiar places? So losing your way in familiar places. Now, all of us do these things, right? You forget where you left your keys, right? You don't remember who's the name of that actor. You know, who has not experienced, you know, driving, and all of a sudden you're not paying attention, and all of a sudden you look around and you say, where am I? And it just, for that split second, you're thinking, where am I? And then all of a sudden it comes to you. Those are not what we're talking about with cognitive decline that can lead to Alzheimer's. It's more when these kinds of things are persistent and consistent and progressive that we show the concern. Traditional cognitive testing is done by what we call pencil and paper tests. This one is called the Montreal Cognitive Assessment, or MoCA. And these tests are based on a 30-point scale. And 26 in the MoCA, 26 to 30 is considered to be normal. 19 to 25 is considered to be mild cognitive impairment. Below 19 is considered to be dementia. And the average for Alzheimer's is about 16. Now, even though those are the most common types of screening tests, those pencil and paper tests, there's a problem because they are prone to underdiagnosis. As noted in this paper in the Journal of the American Board of Family Medicine, published a couple of years ago. And what they noted was common dementia screens are insensitive to subjective deficits. And I've seen this not infrequently, where someone will go to their doctor and they'll say, I feel like my memory is just not as sharp as it used to be. And the doctor will administer one of those pencil and paper tests, for example, the MoCA, and the person will score 27 or 28. And the doctor will say, oh, you're normal. But the person will say, yeah, but doc, I used to be so much sharper. I used to be able to add numbers in my head. I used to be able to calculate a tip without using my phone. I never needed to use a list going into the grocery store. And those things have changed. And so these screens, because they're insensitive, they may lead to dismissing valid concerns that deserve preventative attention. And because of this, more sensitive cognitive screening tests have been developed, including one called the CNS Vital Signs, which is a computerized assessment used to evaluate cognitive performance, which has been validated and as being reliable, and it's more sensitive than the MoCA in the identification of MCI. What you're seeing here is this is a guy I worked with a few years ago, 2017, 59-year-old male who scored normal on the MoCA. And yet you can see in these components of memory, he scored in the very low range. So this test is much more sensitive. It gets more granular, and it can pick up more subtle deficits that we can then target specifically with specific brain interventions. We also use a specialized type of MRI called NeuroQuant, not on everybody, but in the vast majority of people we work with, we like to get this. And it measures the volumes of the brain structures that are commonly damaged by Alzheimer's disease. And it can help us to identify neurodegeneration and the pattern of neurodegeneration in early stages. So once we've established the level of cognitive decline, the next step is to identify the contributors. And these can be metabolic, immune system, infections, toxins, vascular changes, head injuries or traumatic brain injuries, and then, of course, genetic risk profile. Dr. Bredesen in 2015 published this paper where he noted that the cause of Alzheimer's is incompletely defined. Now, what's interesting is that was in 2015, 7 years ago, and it's still incompletely defined. However, multiple studies have implicated metabolic abnormalities and expanded metabolic profiling. In other words, very, very detailed laboratory testing reveals readily distinguishable subtypes. And these are the subtypes that contribute to cognitive decline. So the metabolic profiling helps us to identify how many of those 36 holes in the roof you have. And typically people that we work with that have cognitive decline have about 20 to 25 of them. And then we can categorize them by subtype. So are an individual's contributions primarily inflammatory? So that would be things like leaky gut, autoimmunity, inflammatory oral bacteria, as I noted, viruses like Epstein-Barr and herpes, and now SARS-CoV-2, the virus that causes COVID. There was a study published just a couple of months ago in the Journal of Alzheimer's Disease that showed that people 65 and older who were infected with COVID showed as much as a 50 to 80% higher risk of developing Alzheimer's within a year. So that's pretty significant. We know that viruses are a significant driver of cognitive decline. Type 2 is atrophic, meaning the loss of something that provides support and growth in the brain. So that can be what's called growth factors that help nerves to grow and help to build synapses in our brains. It can be hormone deficiencies or nutrient deficiencies. Type 1.5 combines inflammation and insulin resistance into what's sometimes referred to as type 3 diabetes. That's starting to be seen in some of the publications that Alzheimer's is referred that way. And type 3 is toxic, and that can be a variety of different toxins, such as metals or air pollution, pesticides, plastics, other common household chemicals, as well as mold toxins. And what Dr. Bredesen found, and I and my colleagues that do this work have found, is that about 70 to 80% of the people that are experiencing cognitive decline that present in this way have some level of mold toxicity. And it could be a mold exposure that you had years ago that you just haven't been able to clear out because of a genetic profile that you have. So that's something that we really take a look at early on. Type 4 is vascular. This is associated with reduced brain blood flow and oxygen associated with conditions like high blood pressure, coronary artery disease, and stroke. And type 5 is traumatic brain injury, concussion. We know that amyloid is built up early on in the cascade of events of inflammation that occur after a head injury. So once we've identified the contributors, the next steps are to remove the contributors, create resilience in the brain. In other words, we know that we're going to encounter these insults. They're all around us. Toxins are all around us. Viruses are all around us. You're going to get infections. You're going to get stressed. Our brain has to be able to encounter these insults, respond to them effectively, and then return back down to its baseline function without overexpressing inflammation and amyloid. So that's what we call resilience. And then we want to rebuild lost synapses and any other structural or functional losses that we see. One of the most critical aspects is to support brain energetics, meaning the ability of nerve cells to make energy. And that is related to brain blood flow, oxygenation, and the function of the power plants in all of the nerve cells called the mitochondria. Dr. Bredesen developed what he calls the RECODE program for reversal of cognitive decline. That is a personalized, targeted, multifactorial program for reversing cognitive decline. So personalized, we look at your individual contributors. How many of those 36 holes in the roof do you have as an individual? Targeted, we identify what are those subtypes that you are expressing and what's the priority for you as an individual. Multifactorial, so we use all of these different lifestyle interventions: exercise, sleep, stress management, brain stimulation, avoiding and removing toxins, targeted dietary supplements, nutrition, all built on a platform of mindfulness. Now, ApoE4 status affects this care plan because it affects the lifestyle interventions related to diet, fasting time, fat absorption, cholesterol profile, effects of the diet, treatment of inflammation, and other factors. So for us, it's important to understand what your genetic risk is so that we can target the lifestyle interventions based on that. Now, I mentioned earlier that starting in 2014, Dr. Bredesen published a series of case reports about his approach. And in July of this year, Dr. Bredesen and colleagues published the first randomized controlled trial on the RECODE program in the Journal of Alzheimer's Disease. And the results of that trial are shown here in terms of change in cognitive score. Now, these results that are shown here are related to those 30-point cognitive screening pencil and paper tests. So with someone with mild cognitive impairment or early stage dementia, if you do nothing, give them no treatment, they will tend to decline annually on those 30-point scores by a little over 3 points, 3.5 points or so. Aducanumab, the most recent drug that was approved by the FDA for removing the amyloid, showed a decrease in the cognitive score by about a little under 3 points. So it slowed the decline more than no treatment. So the decline was not as rapid. You still got to the same place. You still declined, but it just slowed the decline very slightly. As compared to the participants in the clinical trial, who on average gained nearly 4 points on that 30-point scale. You don't see that happen with a drug. 84% of the participants in the trial improved their cognition. Not slowed the decline, but actually improved their cognition. And again, this has never been seen in a drug trial. Now, when we talk about drugs, we often talk about adverse effects or side effects. And in this program on Dr. Bredesen's approach, there were additional findings in the way of side benefits. such as a reduction in inflammation, reduction in hemoglobin A1C, reduction in insulin resistance. And these two are what we use to diagnose diabetes. So a reduction in risk for diabetes, an improvement in cholesterol profile, and an increase in vitamin D. In addition, we saw changes related to brain volume. Now, gray matter is kind of the business part of the brain. It's the part that does the work. And those volumes in the study participants increased by about 0.3%. By contrast, people with no cognitive symptoms tend to decrease by 0.83 per year. So the participants in this trial with mild cognitive impairment increased their brain volume. That means that they increased the number of nerve cells. They increased the number of synapses, because that's what makes up gray matter. Those with Alzheimer's tend to decrease their brain volume by about 2.2%. And when we look specifically at the hippocampus, the part of the brain that is typically associated with short-term memory and is very often initially the target for Alzheimer's disease, the volumes in the study participants decreased by an annual rate of about 1.3%. Now, to put that in context, again, cognitively stable folks, people with no cognitive decline, tend to decrease the volume of their hippocampus by 1.4%. So it slowed the decline or in volume of the hippocampus in people with MCI versus people with no cognitive complaints. And in patients with MCI or dementia, typically they decline by about 3.5%. Now, earlier, I showed a graph about the conventional consensus regarding the progression of cognitive decline that showed a decrease in brain function with normal aging, and also the downward spiral that can occur from cognitive decline leading to dementia. This graph shows that before the current healthcare system, humans tended to die earlier, and that was typically from infections or trauma. With the current standard of healthcare, we tend to see a longer lifespan with a gradual decline in health and vitality, including declining brain health. But research supports a third option. Through a personalized, lifestyle-based approach, we may have the possibility of a new trajectory. One that combines more consistent quality of life and the overall length of life to support health and vitality over the health span. Now, based on what's known about the underlying causes of Alzheimer's disease, Dr. Bredesen suggests that it's 95% preventable. And in fact, Alzheimer's disease should be a very rare disease. We've shown that the brain changes that can lead to cognitive decline and dementia start decades before symptoms. And while some in the conventional medical community acknowledge the importance of prevention, most physicians are simply not trained to assess for the underlying causes of cognitive decline or to recommend individualized lifestyle-based strategies for prevention or reversal. Also, it takes on average about 17 years for new science research to make its way into clinical practice. So it's possible that your doctor may not even be aware of the information that you've seen this evening. And in addition, the conventional medical approach does not have any therapeutic option until a diagnosis of MCI or dementia is made. Now, we've also shown that it is possible, when caught early in the degenerative process, to stop and potentially reverse cognitive decline by addressing the underlying contributors. We encourage you to take action now to identify your risk factors and take proactive steps because your mind and body today are the results of your habits yesterday, and your mind and body tomorrow are the results of your habits today. So choose wisely. I want to thank all of you again for spending your time with us this evening. I know it was a lot of information, and I hope that what you've seen this evening inspires you to take action to support your brain health. We have different programs available to help you to do just that. So if you'd like to explore these options further, again, please click on the link in the chat to schedule a complimentary discovery consultation. And also, please be sure to let us know in the Q&A if you want the recording. So let me see if we have any questions that came through. Are there tests for mold in the home? Yes, there are. So the testing for mold typically starts with a urine test to test for the toxins that mold produces in your body. And if we find that, the next step is to test your home, because if you have mold toxicity, the number one aspect is to avoid exposure. So there are tests for the home. There's a variety of different tests that you can use. There are some that we recommend and others that we recommend. We have recommendations for contractors who are well-trained in the types of qualifications we like to look for. And so all of that information is available. Question about what was the trial, Bredesen's trial. That was published in July in the Journal of Alzheimer's Disease, and it was called a precision medical approach for cognitive decline. Next question is, does diet lead to inflammation? Well, it can, because a lot of the foods that we eat are inflammatory in nature, just because of, for example, processing. But you may also have sensitivities to certain foods that can cause an inflammatory response. And there are a number of other things that can lead to inflammation. As I noted, toxins, infections, nutrient deficiencies, a whole variety of things. How many total were in the aducanumab study? In the eMERGE study, it was about 1,600. There were two studies, eMERGE, and I don't recall the other one, but they were both about 1,600 people. Okay, other questions. My son has had multiple concussions. Does that put him at risk? Head injury is a risk factor for cognitive decline in Alzheimer's. There is a cascade of inflammation that occurs after head injury. And very often that inflammatory process lingers and causes long-term damage in the brain cells that accumulates and can eventually lead to symptoms. There's also a relationship between head injury and the gut through what we call the gut-brain axis. And very often, if you get a head injury, you'll get what we call a leaky blood-brain barrier and a leaky gut. And that can drive more body-wide or systemic inflammation. My mom has Alzheimer's. Does that mean I will get it? No, it does not. My mom had Alzheimer's, and I have no intention of getting it. Your genes are not your destiny. First of all, you don't know if you inherited the gene that increases your risk unless you test for it. Now, a lot of conventional medical doctors will say, don't test for it. And the reason is that they think that there's nothing you can do about it. So it will only create stress in your life, knowing this. But the exact opposite is true. I tested myself. I happen to not have inherited that gene. But I will tell you personally, if I did inherit it, it would have been a kick in the butt for me to get even more dialed in my prevention. Let's see. Will a program like this work for someone already taking dementia medicines? Well, as we noted, that the earlier we make these interventions, the better. And so what we want to do is catch somebody early in the process. There have been a few subjects by some of Dr. Bredesen's colleagues where they've shown some improvement in people with dementia. Dr. Bredesen does want to do a study on severe dementia. He has not yet put that together. So for the most part, we say, get on this early because it's really not as effective for someone with dementia as with the early stage of subjective cognitive decline or mild cognitive impairment, or someone who is not experiencing symptoms but really wants to engage in prevention. Let's see. I see a bunch of you guys asking about the recording. By the way, thank you especially for those of you on the East Coast who have stayed up past your bedtime to hang with us this evening. Let's see, any other? Are there any anti-inflammatory drugs of use? Great question. There have been clinical trials with anti-inflammatory drugs, and every one of them has failed. So the anti-inflammatory drugs in general, they have a hard time getting into the brain past the blood-brain barrier. So the first challenge is, how do you get them in there? And then the second challenge is stopping inflammation when the inflammation is there because you have something like a toxin or infection, just allows that toxin or infection to flourish. So it's not a good idea to stop inflammation. Our bodies have natural processes to ramp up inflammation, for example, to fight an infection, kill that infection, and then resolve inflammation. And we have the ability to do this as long as we provide the nutritional building blocks for those chemicals. It's been shown that the resolution of inflammation pathways are impaired in Alzheimer's disease. So supporting those resolution pathways, and we can do that with diet and targeted dietary supplements. Let's see. Is increased estrogen in menopause a risk factor? What we typically see actually is I'm sorry, I read that wrong. Decreased estrogen in menopause a risk factor? Yes, it is. And there's a lot of controversy about estrogen replacement. A lot of medical doctors will say that after the age of 60, women should not be on estrogen replacement. That was based on flawed studies, and those have been refuted. Talk to your doctor. Find somebody who is knowledgeable about bioidentical hormone replacement. It has been shown to be a game changer for women that are experiencing cognitive decline. And there was a study done at the Mayo Clinic that showed that women who get hysterectomies before age of 40 that are not put on appropriate hormone replacement therapy double their risk for Alzheimer's disease. An example of a toxin. Well, mold is a good example. Mercury, lead, aluminum, cadmium are all toxins. We consider actually tick-borne illness to be both infectious and toxic. So those are some examples. If a TBI is 40 years old, do you think I've outgrown the negative effects? Maybe. It's hard to say just from that information. What we know is that cognitive decline is multifactorial, and brain injury is a known contributing factor. And for example, we see kids that play football when they're young. They can start to accumulate changes in their brains. And we've seen like kids that play like like little league, pee wee league type football, and then they die in their 20s, and they do autopsies and they look at their brains, they have indication of chronic traumatic encephalopathy, or CTE, which is the pathology that a lot of the professional football players get. Those of you that are watching this evening from Denver, this is something that Demaryius Thomas had. So the impacts of a brain injury from 40 years ago could still be a contributing factor. It's hard to say, from here, but it could be. To follow up on the question about meds that reduce inflammation, are there supplements that will reduce inflammation? Yes, there are. There are very effective supplements. In fact, and I didn't bring this up because I haven't had a chance to read the study in its entirety. Yesterday, there was a study published in the Journal of Alzheimer's and Dementia that showed that low vitamin D levels are a contributor to cognitive decline. And it was a particular form of vitamin D, vitamin D3. And one of the things that vitamin D does is it's anti-inflammatory. It supports immune function and it's anti-inflammatory. And so that's an example of a supplement or a nutrient that will reduce inflammation. Question here, West Nile virus, HPV, Legionnaire's disease. Yeah, any virus, if it can make its way into the brain through what we call a leaky blood-brain barrier, and the blood-brain barrier, that's designed to prevent toxins and things like that from getting into the brain. But that tends to break down. It breaks down from a head injury, certainly. But over time, it can break down because of these accumulated insults that we've been talking about. And so if the blood-brain barrier breaks down and any virus or any bacterial infection makes its way into the brain, it can be toxic and start this process. One of the most common is called endotoxin. Now, this is a bacteria, and it's associated with the gut bacteria. Now, if you have leaky gut, an endotoxin gets through the gut barrier, it ramps up inflammation dramatically, and it can actually get into the brain and bind to the brain's immune cells and cause the onset of inflammation. So any infection can be a driver. What are these 36 factors? That is a very, very detailed question. Too much for me to answer all of those today. How do you reduce brain inflammation after a head injury? That's a good question. First thing you do is protect the blood-brain barrier. Second thing you do is protect the gut barrier, because if you get a leaky gut from a head injury, it will actually cause the blood-brain barrier to weaken, and then you can continue to get toxins and infections into the brain. So those are two things that are really important. It's also important to note that small intestinal bacterial overgrowth, or SIBO, is very common after a head injury. So that's characterized by, most commonly, gas or bloating after you eat, especially carbohydrates. And so SIBO can actually increase inflammation in the gut. And if the gut's inflamed, the brain will be inflamed. So there's this crosstalk after a head injury between the gut and the brain. So we have to address both ends. If the studies show that some meds slow progression, what is the downside of following your protocols and taking the meds? That's a great question. So let's say that you have a virus in your brain. Let's say you have herpes virus, because that's one of the most common viruses. In fact, Dr. Tanzi, who I mentioned a couple of times today, he found that if you do autopsies on the brains of people with Alzheimer's and you open up the amyloid plaques, you'll find viruses inside, herpes viruses in particular. So let's say you get a herpes virus in your brain and the amyloid is being overexpressed in order to attack that virus. What amyloid does is it actually engulfs the virus. so that that virus can't spread to other nerve cells. Now, if that amyloid is there as a protective mechanism, removing it before you address that insult or that virus could allow that virus to proliferate and damage more nerve cells. Dr. Bredesen says that the drugs can be a very, very effective approach on the back end. After you have addressed the insults that cause the overexpression of Alzheimer's. And so he says that probably in the future, the best approach is going to be some combination of prevention, lifestyle intervention, and drug therapy, but we're not there yet. So that's the problem with getting on this type of drugs. Natural ways to remove mold. Great to see you on here. Supplements, herbs, practices. Yeah. So number one, get out of the exposure. That's number one. Number two, mold for some people, mold likes to bind into fat tissue. So what we have to do is we have to pull it out of the fat tissue, attach it to something that'll carry it to your digestive tract, run it through your liver, mix it with your bile, and excrete it out in your stool. But the problem is that 90% of what gets mixed with your bile gets reabsorbed. So you have to bind that toxin bile combination with the use of binders, dietary supplements. There's also prescription medications that can do that as well. And so what that does is it prevents the reabsorption. So we pull out of the tissues, we attach it to a carrier, we bind it in the intestines, and then we eliminate it in the stool. And there are supplements that can be used for each step of the way. If I work with you, how long might it take me to see some improvement? That's a great question. So typically it takes about 3 months minimum to get all of the pieces in place because there is an extensive amount of testing that we have to do. So typically it's going to take about 3 months. Now, we don't wait 3 months to start treatment. We get on this right away. We look at your diet and we work with just phenomenal people for health coaching that help us to create the diet that's most effective for you. And so we start on that right away. Typically, after everything's in place, it takes about 3 to 6 months to start seeing meaningful change. And what you typically see is the rate or amount of the decline stops. There's no further decline. And then slowly it gets reversed. It's like if you've got a boulder rolling downhill, you've got to stop it from rolling any further, and then you could slowly push it back up. And we evaluate regularly with that pen and paper test. That test has been, the MOCA in particular, has been shown to be valid if it's tested monthly. And in fact, I just saw a gentleman in my office yesterday that over the course of 2 months, his MOCA changed from 22 to 25. It went up from 22 to 25, and 26 is a normal test. So he improved greatly in a couple of months. Now, he's been on the program for about 7 or 8 months now. So we've had a lot of work done, but that's how we would test and evaluate your progress. I think that is all of the questions. Have I missed any? I don't think I have missed any. I think that's it. Okay. Well, again, thank you all for spending your time with me this evening. I really appreciate you being here with us, and I hope you have a great rest of your evening.